In addition to understanding patients who develop intolerance to the novel agents, another really important area is understanding and being able to predict potentially patients who develop resistance. So these are patients where the inhibitors fail them not because of intolerance, but because they have progression of disease through the agent. For Venetoclax, we've seen, published, and heard, and will hear at this meeting, biological mechanisms of resistance. In other words, in following patients on these drugs, what are some identifiable mutations or other biological changes that happens when they progress. What it doesn't answer, and what we're trying to look at, is are there readily available patient factors that will help you better risk stratify who would develop that resistance. So not when they develop it, but at the start when they're going on the drug. In other words, can there be factors when you're considering a patient higher risk? And this particularly might become important as we see more trials looking at combination therapies. In other words, if patients at higher risk, it might lead to a group or a population you'd want to intervene upon before the resistance develops. So one of the things that we looked at and will be presented in the poster session is looking at the role of the CLLipi score for predicting progression-free survival in patients treated with Venetoclax. So this was patients treated off trial with Venetoclax from multiple U.S. and international centers, and we looked at the CLLipi score for two main questions. One, as I just alluded to, looking at if you could predict PFS, but the second was, are these factors in fact readily available? So the CLLipi score, which was validated and published a number of years ago, takes into account patients that have either deletion 17p or TP53 mutations, their IGHV mutation status, their clinical stage, their age, and their beta-2 microglobulin status, and those are weighted, and patients can get points for, or assigned points for higher risk status of any of those markers. And then the total point places them into a very high, intermediate, or low risk category. So a couple conclusions from our poster was, one, despite including many larger centers, there was a very small percent of patients that had all those markers available. So in fact, so small that rather than use that complete score to look at the progression-free, we used what we call the available score, meaning if this is real world, just take the score points, and that became the point category. And what we found was that there was a significant difference between those in the lower intermediate. We grouped those patients, since it was a small number, versus the high, and the lower intermediate versus the very high in terms of predicting progression-free survival. However, when we looked at a multivariate analysis of the IPI score, along with other factors not included, such as the complex karyotype or deletion 17p alone, what we found was really what was driving it was the complex karyotype. And this, in fact, has been published by Anderson and al. And other groups. So again, I think we're back to a little bit drawing board of, we have great clinical tools that were very important in the era of chemoimmunotherapy, but now how potentially complex karyotype, what other really key factors at baseline might identify the highest risk patients that need earlier intervention or closer following or closer surveillance to intervene before they progress.